The explainer.
Welcome to this clinical walkthrough on the Metatarsalgia case for the UKMLA exam brought to you by Mediate. This is such a common scenario you'll see in general practice, and honestly, nailing the structure is absolutely key to passing. We're going to break this down into 6 clear stages. We'll start with opening the consultation, move on to taking a focused history, then the exam, the diagnosis, creating a management plan, and we'll finish up with closing and safety netting. All right, let's get right into it. A strong opening is so important. It's how you build immediate trust and set a really professional tone for the entire station.
This phrasing here is perfect. It's polite, it's professional, and it gets straight to the point right after you confirm the patient's identity. You're showing them you're already aware of their problem.
Now for the history. Look, to score well here, you need a structured approach. It helps you gather all the information efficiently without missing any of those key details.
For any kind of pain history, your go-to framework has to be Socrates. So let's walk through exactly what you need to ask for this specific case. For sight, you want to be specific to help guide the patient. In metatarsalgia, you're expecting them to point right to that area under the metatarsal heads, the bones at the base of the toes.
For onset and character, you're starting to build a picture of the condition. A gradual onset points towards an overuse injury, which fits perfectly with metatarsalgia. And the character of the pain helps you differentiate it from other causes.
Now, these questions are powerful. They're your screen for nerve involvement. If you get a yes to tingling or that classic walking on pebbles sensation, that should make you immediately think of Morton's neuroma, which is a key differential.
These questions help you get a handle on the mechanical nature of the pain. If it gets worse with activity or with certain shoes, that is pointing strongly towards metatarsalgia.
Next up, screen for risk factors. The patient in this particular scenario is an estate agent, so asking about standing and walking is crucial. And questions about their footwear, activity levels, and foot shape help to complete that clinical picture and confirm your suspicion.
Don't forget to do a quick general medical screen. A great framework for this is MAF-TOSA. You have to remember that conditions like rheumatoid arthritis or diabetes can also cause foot pain, so you've got to screen for them. Always address the patient's ideas, concerns, and expectations. This shows a patient-centered approach, which is vital for getting high marks in communication. It shows you're treating the person, not just the foot.
Okay, let's move on to the examination. Your goal here is pretty simple: confirm the suspicions you have from the history and rule out those main differentials.
Here are your expected findings. On inspection, the foot is probably going to look completely normal. The key sign comes on palpation, that distinct tenderness right over the metatarsal heads. Sensation and pulses will be normal, and a toe squeeze test shouldn't produce a click.
So, this is the crucial point you have to get right. Metatarsalgia is pain under the bones, an ache that gets worse with pressure. Morton's neuroma is pain between the toes, and it's often a burning, radiating pain with those distinct nerve symptoms. Your history and exam must distinguish between these two. So you've gathered all your information and you've formed a diagnosis. Now you have to explain it to the patient clearly and without any of that medical jargon.
Your provisional diagnosis is metatarsalgia. This is a simple, clear definition that you can easily adapt for your patient.
And this is how you explain it. You link it back to their story, their job, their footwear. You explain the simple mechanism of inflammation from impact. This empowers the patient with understanding, and it makes them much more likely to stick to the management plan.
And just a reminder, mastering this really comes from practice. You can run through this exact case right now and get objective feedback on mymediate.com.
Okay, let's build the management plan. This needs to be a collaborative process with the patient, and you're going to start with simple conservative measures.
Your first-line advice is practical and effective. We're talking simple pain relief, clear advice about footwear, recommending some over-the-counter insoles, and modifying their activities. These 4 points are your immediate treatment package. You also have to outline what the next steps are. If things don't get better, physiotherapy for targeted exercises is the next logical step. An orthopedic referral is reserved for cases where conservative treatment fails. This shows you're thinking about the patient's entire care pathway. Finally, a safe closure. You must provide clear safety netting advice and confirm a follow-up plan. This is a non-negotiable part of any consultation.
Your safety netting has to be explicit. Tell the patient the specific red flags to watch for: pain that's getting worse, if it affects their ability to walk, or any new numbness, tingling, or bad swelling. If they experience any of those, they need to come back.
So you'll conclude by giving them a patient leaflet,
arranging a clear time frame for follow-up, say 4 to 6 weeks, and most importantly, checking their understanding. Asking, "Does that all make sense?" gives them that final chance to ask questions and ensures you've communicated effectively.
To be fully prepared, you should practice this exact case on mymediate.com. Go through all these steps, perfect your phrasing, and you'll walk into your exam with confidence.